Hey there, this is Deborah Guthman, a third year in the DPT program at UNC. I've been researching chronic pain, central sensitization, and nosoplastic pain really since my first year. I got to spend a lot of my last year applying this knowledge to the clinic. I treated patients at the VA with chronic low back pain, centralization, and all of that. It was an amazing experience in which I applied my knowledge to patient cases. Though you have a ton of science behind the chronicity of pain and know what pain neuroscience education is, this presentation is to give you better language to communicate those difficult topics to your patients. I'm assuming that you have the neuroscience behind such topics, and I won't spend too much time on the details behind each education piece. I'll also incorporate some patient examples because if you're like me, application is what cements topics. Have you guys experienced the patient avoidance thing yet? A clinician sees a name on their schedule and just shudders. And when the patient comes in, sticks some modalities on him or her and provides some pelvic tilt stability exercises. Chronic pain is hard for the clinician, yes, but so much more for the patient. Often, years go by and they receive little relief or help from numerous professionals. So why are we doing this? Why P&E? The hope is that through this education, our patients will reconceptualize their pain experience. They'll know and understand what's behind a twinge, and therefore it'll lessen the threat of such responses. This works to decrease their stress response, and we know that in the long run, this reduces the intensity, the disability, and the fear associated with their pain. By emphasizing that long-lasting pain is much more about nerve sensitivity than tissue damage, and providing the neuroscience for it, we can transform their experience. There's also compelling evidence that P&E improves patients' outcomes. One such study is a systematic review of 13 random control trials that that shows that the use of P&E in combination with other treatment interventions reduces pain and improves function while lowering disability, enhancing their movement, and minimizing healthcare utilization. So that's why we're doing P&E. All right, so where do we start? I really like this general protocol that Joe Niche created. It's just a couple of steps that can guide your application of P&E to your clinical practice. I actually used it last year when I saw patients at the VA, and it's just really helped guide me a little bit. So the first step is to identify the patient that's appropriate for the education. You've been learning how to do this, how to identify nosoplastic pain, paying attention to their diagnosis, their history, and their clinical presentation, like fear, catastrophizing, and hypervigilance. You can use outcome measures, like the pain catastrophizing scale, the FABQ, and others. But once you've identified the patient with maladaptive beliefs that are going to affect their clinical outcomes, then okay, P&E needs to be incorporated into their plan of care. The second step is to begin education. You can begin education day one at the initial eval. Often an introduction to just what pain is and basic neurophysiology can fit into the end of the session. The massive amount of information that you're trying to communicate can be overwhelming, but people like Lau, Mosley, Niche, and others have found that as little as 30 minutes of face-to-face education is beneficial for patients. Remember that you can also do education while your patients are doing active treatments. There are many times when a patient would be on the treadmill or on a bike or on a modality, and I would also be giving education. It doesn't all have to be seated discussions. Education should cover general nerve physiology, pain physiology, and provide an explanation of central sensitization. The information given should be specific to your patient's needs, their beliefs, and the presentation that they and their presentation. The third step is to reinforce with homework. Because this is all really new information, review is often needed. Patients would return to the clinic and not remember most of what was discussed last session. Various clinicians have proposed methods like online videos, a booklet, or emailing patients in between sessions. You can also review concepts while you're face-to-face, but it's helpful to give them something. I often use Greg Layman's pain workbook. You can find that workbook and the resources on Sakai. But it was just a great review of general P&E topics. The fourth step is to correct. It's important to keep addressing maladaptive beliefs. They keep popping up even after weeks of treating and educating. You can use Lau's neurophysiology of pain quiz to test a patient's knowledge and target their education again. This quiz is free online, but I also provided it in the resources. Apply. As you continue to work with your patients, continue to speak on education topics. If they come in after a stressful week and you notice they're in more pain, it may be a great opportunity to pull a story out of your toolbox and educate on the influence of stress on pain. So there you go, 5 steps. Now let's get to the education piece. So how do we communicate these difficult topics? Stories can be used to illustrate difficult concepts. They can be rearranged and manipulated to fit a patient's needs. Remember, it depends is the catchphrase of physical therapy. These stories are meant to help guide you in breaking down incredibly complex ideas into manageable bits. They are just guidelines, though. These stories included are the ones that are most commonly used by myself, by other clinicians, by my mentor, a therapeutic pain science specialist. But there are many more that can be included and adapted to your patient as needed. The first story, alarm systems and nails. This story introduces nerve and pain physiology. It's important for your patients to understand that injury and pain aren't the same thing. Pain is an output from the brain, and tissues don't send pain signals to the brain. So here is an example of what you can say to your patients. All right, patient, let's talk about what pain is and why you may be experiencing it. Let me tell you a little bit about nerves. If we laid your nerves out end to end to end, there would be over 45 miles. Over 400 nerves make up your system. You have nerves that go from your fingertips or your muscles or your skin to your spine, and from your spine to your command center or your brain. There's always a bit of electricity in your nerves, and when enough electricity enters your nerves, it sends messages towards your brain about whatever got it excited. For example, nerves fire when you step on a nail, but stepping on a hair isn't enough input to raise the electricity in your nerves. So no message is sent about that hair to your brain. Do you want to know why pain happens? I'm going to explain it with another little story. You're walking down the street and you step on a nail. You want to know about that nail? Of course. So the nerve receptors in your foot send messages called nociception to your spine about the pressure, the temperature, or other sensations it gets from the nail. The spine can then respond by ignoring it, or if it feels it's important, it sends those messages up to your command center. If the brain gets that information, it interprets it. If it believes that there's a genuine threat, it sends pain sensations down into your foot, so you immediately hop off of it and give it the attention it needs. Pain is good. It's like an alarm system that is meant to alert you to a threat. But now imagine you're crossing a busy road, you step on a nail, and a massive bus is roaring towards you at the same time. Do you feel a nail? No. Do you stop and mess with your foot when a bus is coming towards you? No. You sprint to the curb and escape a terrible accident. Maybe once you calm down a bit, you start feeling the cut in your foot. So what's going on here? Your brain takes in all the messages it's getting from its nerves, all the nociception. It gets the messages about a cold, sharp pressure in your foot, but it also gets the message about a giant bus careening towards you. It determines that the bus is the greatest threat and doesn't produce pain, so you pay attention to the bus and you sprint out of the way. Maybe later, once you calm down a bit, you'll feel the nail and take care of your foot. This story tells us that pain is something the brain produces in response to a threat. Sometimes you can have an injury and not feel it, but the opposite is true too. Your tissues can be healthy and yet you are experiencing pain. In fact, many people who are in severe pain will have negative diagnostic tests. Is that your experience? Remember, the brain evaluates all the threats it's receiving. Threats can be stress, anxiety, emotions, injury, a speeding bus, and it may produce pain for protection. Pain is an alarm system, and it can be helpful, or it can be just loud and intrusive if it's not working correctly. All right, this next image and story describes changes in your nerves, which lead to firing and can also lead to sensitization. I typically present the story to every patient, especially the ones who are highly sensitive. So remember the electricity in your nerves and how a certain amount is needed to send messages? Like here, I'm tapping on your knee and you can feel it. But now I'm lightly touching you and you can't. Nerves need enough of an input to send messages. So you step on a nail and it's enough to raise the electricity amount, sending messages to your command center. After you get injured, though, the electricity in your nerves stay high for a little while. Have you ever gotten a paper cut? Even after your skin closes up, maybe that area stays a little sensitive. That's because the electricity ramps down. It doesn't go from 10 to 1. It takes time, 10, 9, 8, 7, 6. This means nerves stay sensitive after an injury and fire more easily. That can be helpful. Like you want to pay attention to that healing area on your foot after you step on a nail. You're not going to go run a marathon on an open wound, right? We know that in 1 in 4 people, though, the electricity stays elevated far outside of tissue healing time. It stays extra sensitive even after the tissues heal. What do you think that means? Yeah, it takes less activity for nerves to start firing and sending threat messages to the brain, which responds with pain. It's like a house alarm that has become way too sensitive. A fire alarm is meant to detect smoke, indicating a fire, right? But when your fire alarm starts going off after a candle is lit or when a piece of toast is being cooked, that's a faulty, highly sensitive alarm. That's how long-lasting pain becomes more about nerve sensitivity than tissue injury. Your alarm is firing even without an actual fire. Mrs. C came to me really frustrated. She was experiencing some relief of her pain, but noticed that weird things would set it off, like cold, arguments with her kids, a long time sitting at work, all made her worse. I often use this next story because it describes one reason why nerves are sensitive and why patients may experience heightened pain with non-related stimuli like stress, cold, or whatever. Nerves have sensors with channels on them that let electricity in and out. Remember those thresholds? Each sensor responds to something specific. It raises electricity in your nerve, and the nerves will send messages to the brain about that sensation. There are many types of sensors, but 5 that are relevant to you are one specific for blood flow, movement, stress hormones like cortisol and adrenaline, immune chemicals, or temperature. For example, it's cold outside and your temperature sensors let in electricity. Nerves fire and send that information to your brain, which responds in a complicated way, but leads you to decide to put on a jacket. If the messages stick around and the brain determines that it's important and it's a threat, it can actually produce more of that sensor type and causes sensors to stay open for longer. What do you think that does to the nerve? Right, more sensors make it more sensitive, and the sensors staying open more mean more electricity in your nerve. As long as these channels are pouring information into the command center about potential threats, the brain continues to keep things sensitive. And you know what? Different types of sensors also explain why even when you're cold, stressed, or sick, you might start feeling pain. If the nerves are sensitive, then cold will start firing off sensors and your nerves will flood information into your brain about a potential threat. The sensitive alarm system starts to go off. But good news, these receptors change about every 2 days. If we can decrease the threat, like your fear of movement or stress, we can calm the sensitivity of the brain and the receptors go back to their normal amount. We decrease the threat through through education about pain and your body and through movement that helps calm down the sensitive nerves. It's common for people with chronic pain, central sensitization, to have widespread sensitivity and pain. Mr. Allen, one of my patients, had a back injury 20 years prior, but at the point he came to me, he was having aches in his feet, shoulders, neck, and would feel widespread issues even after just like a stressful day. This illustration that I'm about to talk about helps patients realize that pain in other areas, spreading pain, is not because there's further tissue damage. It's just because sensitivity spreads. So, your nervous system is like an alarm in your home. When someone breaks in, the alarm goes off and you're alerted to the problem. With sensitivity, though, your alarm starts getting triggered by a leaf fluttering by. Your nervous system is all connected, right? Those 400 nerves, 45 miles. Every nerve is related and shares a connection. So when your alarm system starts going off, neighbors start waking up and their concern spreads up and down the street. Their alarms might get set off too. And the police come to investigate, further going from house to house to house, waking people up and trying to figure out what's going on and what's setting off the house alarms. The area you're experiencing continuous pain has a sensitive alarm system, which is going off constantly. It has begun to wake up neighboring nerves, and immune cells come to investigate that area. Just the presence of immune cells leads to further sensitivity in areas away from the site of your first discomfort, like the policeman waking up other neighborhoods to see what's going on, to investigate. That's one of the reasons why your feet start to hurt even though your back was initially the issue. Your neighboring nerves are waking up. It's not because your tissue is damaged, it's because there's spreading nerve sensitivity. Patients are going to be curious about how you're going to fix them. How are you going to fix these sensitive nerves? What can they do to calm down their on-fire nervous system? Based on research, there are several solid options. Education to decrease fear and sensitivity, physical activity, because graded movement increases blood flow and oxygen, amongst other things, and medication and stress relieving techniques, a ton of other things. But this is just a story to explain that to your patients. So you've got a sensitive nervous system. Now what? Research tells us that we can calm things down. One big way is through teaching people about their pain. It works to help you understand what pain is, and that pain doesn't mean injury. There's been a lot of research that education alone is as effective as many very strong medications like opioids, and it doesn't have any harmful side effects, while other medications have minimal to severe side effects that are really distinct possibilities. Can you think of negative side effects of medications like opioids? So research also tells us that physical activity is really important. Rest and activity doesn't help a sensitive nervous system. In fact, it actually makes things worse. Nerves love space and blood. Improving blood flow makes the nerves happy and calms the system down. You don't need to become a gym rat either. Anything that causes a little sweat is more than enough. Medication can also be helpful. Ask your doctor. There are specific medications that work to reduce sensitivity. The brain has its own medicine as well called endogenous opioids. It's produced with exercise and it washes the brain with chemicals that are natural pain relievers. Can you think of other calming things? What things calm you down? Heat, stress relievers, movement. What else? So many patients have complaints not specific to a pain sensation. In my limited experience, patients talk about difficulties with concentrating, memory, and even coordination issues. Mrs. Camp, one of my patients, had difficulty discriminating touch on her feet and her back and felt like her body was wonky. She noticed that her short-term memory had gotten so much worse, and amongst other things. She was super stressed out because it felt like there was irreparable damage from her pain. This story is helpful to further describe the complexity of pain and why chronic pain impacts many areas of a patient's life. If you remember from your readings, it describes the neuromatrix theory of pain. For a long time, it was thought that tissue damage causes a light bulb effect. It turns something on in your brain, and that's pain. But if that were the case, pain treatment would be simple. Cut that area out. We found that there are 9 areas, at least, in your brain that communicate to produce a unique pain map. The map is activated whenever your brain perceives a threat and is creating pain in response. These areas have other jobs as well, like memory, coordination, focus. Imagine your brain as a company. When there is long-lasting pain, the brain calls a meeting with all the needed different parts. Because of this, there are less and less people working at their primary jobs, and the understaffed places begin to have issues. That's why people with long-lasting pain often have memory problems or difficulty with emotional regulation, discoordination. Thankfully, though, the more you learn about what's going on, the more your brain calms down because there's not such a huge threat. People, or areas of your brain, go back to their primary jobs and the function starts to get back to normal. I use this story a ton. Patients don't often get how fear or stress, emotions, life circumstances impact the intensity and duration of their symptoms. They're frustrated with themselves. This is a great story to illustrate the body's stress responses to pain and how it sensitizes the nervous system. It also reinforces how our treatments work by changing a lion into a less threatening cub. Imagine that a lion roars into your room. What do? Your heart races, you jump out of the chair, your blood is rushing, you get tunnel vision and you're ready to run or fight. Are you thinking of your posture, your digestion? No, everything in your body is primed to help you respond. There is less attention and resources given to things like digestion or sleep, and the blood is shuttled to large muscle groups and away from things not involved in flight. But if the zookeeper comes and takes the lion away, what happens? You calm down, your heart slows, you stop sweating, and you return to balanced function. In this example, the lion is a metaphor for the stress associated with your pain, your anxiety, your fears, your failed treatments, house payment, your sick mother, and your moody teenager. If the lion is taken away, if your stress is managed, then your body calms and returns to typical function. However, if it stays, your system involved in fight or flight stays hyped up. The lion follows you around and your system stays stressed. This steady, prolonged stress state leads to a ton of changes in the body. Sore muscles, you might have sore, smaller muscles of posture because remember, blood is shunted away from these areas to large muscles for running away. Mood swings from stress hormones, changes in appetite and weight, sleep changes, sensitive nerves, irritable bowels, and issues like fatigue and depression. So, what do we do about this lion? You can't just totally get rid of it. Your kid doesn't have a personality transplant, and your pain doesn't evaporate. But we can change the lion into a cub. If a cute little cub plods into your room, do you jump up and scream? No, it's not scary. We can do the same thing through decreasing the threat associated with your pain. Through education, engaging in movement that improves blood flow and decreases fears, and using stress coping strategies. You now know that pain doesn't mean huge, dangerous tissue damage. That helps. Now, when a cub saunters into your room, you no longer react with such intensity. Your system is calm, and those other stressful things, they need to be coped with as well. What are some ways that you can think of to calm things down? People really get stuck on imaging. Mrs. Camp, the patient I mentioned earlier, kept bringing up her MRI and x-rays that described bulging disc and arthritic changes in her spine. She felt like it was the reason for her pain, and that pain was an inescapable consequence of such evidence. So what I'm going to just pretty much list off some studies, and you can pick and choose from which ones you want. But this story will just be a way to assure patients that tissues heal and that even when things show up on imaging, it doesn't mean pain. So, Mrs. Patient, you've been describing your pain as a result of an injury, like the area hasn't healed. But tissues heal in weeks to months. So pain 5 years out from an injury doesn't mean tissues haven't healed or that something's still broken. Even when imaging or diagnosis indicates something like a tear degeneration, research shows that it doesn't correlate with pain all the time. People who have positive findings on imaging don't necessarily have pain. In one study, the study took MRI images of a bunch of people and found that 40% of all the people without pain had bulging disc, but no pain. Another study took images of shoulders after a torn rotator cuff repair and successful rehab and found that over 90% still had things show up on their imaging, although they didn't have pain. In fact, in patients over 70, they found that 2/3 have asymptomatic tears. That means a tear without any pain. For knee pain, well, the huge research study found that there's only a 50% correlation with pain and arthritis. So if 100 people had arthritis on their imaging, evidence of arthritis on their imaging, only 50% had knee pain. In a systematic review of 5,397 knees that weren't painful, it found that 43% of those had evidence of arthritis but didn't have pain. One of my favorite studies found that 35% of collegiate basketball players without pain had significant abnormalities on their MRI scans. What this means is some had meniscus tear, some had joint narrowing, some had evidence of, degeneration, but they didn't have pain. They're playing college basketball. You see, many people can have these same injuries, and it doesn't mean pain for them. Prolonged pain is more about nerve sensitivity than tissue damage. Even age-associated changes in your bodies, like wrinkles on your face, doesn't mean pain. I love this story. One of my patients, Mr. Allen, I mentioned him earlier, he had such a stressful job. And when he tweaked his back moving a box, it initiated years and years of intense pain. This story is helpful to describe how the environment and extraneous factors like emotions impact the output of pain, the brain's interpretation of a threat, not only when first injured, but also throughout the healing process. Research shows that what happens around an injury can determine how much pain a person has. Remember your alarm system? When it's set off in a stress-filled context, it becomes extra sensitive and wakes up with a vengeance, taking forever to calm back down. These emotions-filled contexts can include things like a car wreck, a surgery, or getting hurt at work. Imagine a cup with some liquid in it. The liquid is stressors. If you keep pouring stressors in, more and more and more stress, the cup overflows. You can imagine the cup overflowing is pain. But if your cup is full and maybe you apply some heat, it starts to boil over. Emotion can be like heat. When combined with stressors that are almost overflowing, it's enough to boil over, leading to pain. Injury in a positive environment is completely different. Think about kids playing contact sports. They get hurt all the time. They have bruises and twists and sprains, but it's pretty easy to recover and not very complicated. Injuries are seen as being part of the team and seen as a badge of honor. My favorite example of this phenomenon is with demolition derby drivers. You know what they are. They crash into each other as part of their job. Although, let's talk about motor vehicle accidents. 1 in 3 people in a motor vehicle accident develop chronic pain after a car wreck. But less than 10% of demolition drivers have long-lasting pain. It's not because they're superhumans either. Imaging and interviews with the patients show that they get the same kind of issues as people in motor vehicle accidents. But this is crazy. They have an average, one driver will have an average of 30 events, so 30 demolition derby events, with 52 collisions per event at an average of 45 miles per hour. Many report some pain after an event, but it is lessened, and they put it into context, they accept it and move on, and it doesn't become long-lasting chronic pain. So, tissue damage and pain are not the same thing. Other things impact the experience. By addressing those other factors, we can reduce pain. There is solid evidence that P&E improves patient outcomes. I can cite the fact that the numbers needed to treat for opioids are 2.5 to 3.9, that the numbers needed for harm are 3 to 9, while P&E, the pain intensity numbers needed to treat is 3, and improving disability numbers needed to treat is 2, but there is no harm. But really, these numbers don't get at the emotion or the human experience of things. A discouraged patient can leave your practice with hope, with less fear, with less disability, with more life. Mrs. Camp came to me on leave from work. She was spending most of the day on her couch in one position. She had canceled trips to Disney with her kids. She had canceled a road trip to visit her sister who was in cancer treatment. And now she was unable to work. After 4 months with Miss Camp, she started going to yoga regularly. She'd gone on 2 road trips to visit her family and hadn't missed another day of work. She was able to spout off pain neuroscience topics. She fully embraced nerve sensitivity and recognized pain as throbs, not threats. If we're talking outcome measures, her FABQ, her RMDQ, and her global perception of improvement no longer indicated a pain problem. Her recovery included P&E, amongst other things. And she was in a place where she embraced treatment. But these stories were part of her recovery journey. They took the fear and the stress out of the pain that she was experiencing. I hope you're able to use these stories in your own practice. So I realized that the whole time I mentioned his name in this presentation, I pronounced Adrian Lowe's name as Lau, but it is definitely Lowe. Disclaimer! These stories, 5 stories, are also really, I use them commonly with patients. Um, I'm not going to go through and talk about each one. Instead, you can find the script in the PowerPoint that's posted. But this is just to give you a little bit more knowledge. Like, there are other stories to describe things like brain map changes and the inflammation response and the learning, like neuroplasticity. So, yeah, these are just to bring your awareness that there are more topics and more scripts that you can check out. Hope y'all enjoyed this.